Hi guys, welcome back. The new topic we're studying is image-based questions related to neurology. Starting with the very first one, he's asking you regarding which drugs are used in the condition shown in MRI head. So it's a two-step question. You need to diagnose the condition, then pick up what drugs are going to be used, and then select multiple correct options. If you look at the MRI head of this patient, you will notice some hyper intense lesions which are going to be looking like fingers. Well, what the MRI head of this patient is showing is technically called as Dawson fingers, which is a feature very characteristic of multiple sclerosis. This disorder is characterized by optic neuritis, including Utto phenomenon, which are neurological features that develop on heat exposure. Especially if this person will take a hot shower or will be having high grade fever, or let me say doing some physical exercise, that is when neurological symptoms like blurring of vision can develop, or weakness in the arms can develop, weakness in legs can develop, spasticity can develop. And because patient is not going to know what is weakness per se, lots of them might actually say cramps, because you see spasticity basically means hypertonia. Now for multiple sclerosis, what are the drugs that are used? In an initial episode of multiple sclerosis, especially when blindness is a presenting feature, we definitely use steroids for management of this condition. Fingolimod is an oral immunomodulator that is useful for management, especially in relapsing, remitting variety of multiple sclerosis. Mitoxantrone, well, I'll say it is a cardiotoxic drug. So if the dosage is a pretty high, that's where the problem will occur. But yeah, it is mentioned in the textbook that yes, mitoxantrone can also be used. In fact, efficacy-wise, it is good. The problem with mitoxantrone is mainly the cardiotoxicity component that limits its usage. But if you look at the last option, intravenous immunoglobulins, we have studied intravenous immunoglobulins for management of Guillain-Barré syndrome. Well, we can use this in management of Kawasaki disease. Then even has been documented, and we have discussed this also in hematology, is used for management of acute idiopathic thrombocytopenic purpura. So option number A, B, C are the correct ones. So the correct answer to this MCQ will be option number 1. Coming to the second question, he has given an MRI head and an EEG of a 35-year-old man with progressive myoclonus and apathy. Well, first, if we focus on the MRI head of this person, you can definitely notice that the gyrae sulci, they look very pronounced. In fact, the technical term that is used to describe the image that is shown here is called as cortical ribboning. Well, if you remember, if I talk about development of myoclonus at 35 years of age, one of the diseases that always should come to your mind is prion disease. One of the features of prion disease can be cortical ribboning. And second, if you look at the EEG of this patient, you will definitely notice slowing and then some spikes present. If I just zoom in, you can definitely notice some spikes present, and they're present diffusely and they're coming at regular intervals. So the EEG of this particular person can be described as periodic, because you can see this spikes present here. That would be called as periodic sharp wave complexes. So a combination of cortical ribboning and periodic sharp wave complexes with a history given of myoclonus will lead us to the diagnosis of variant Creutzfeldt-Jakob disease. Well, as I had hinted earlier also, whenever you read about myoclonus, you should anyway be able to solve the question why, because when you focus on this term myoclonus, if it is occurring before 1 year of age, or he is giving you a scenario of an infant, you have to think in terms of Salam seizures, that is West syndrome. If the same manifestation of myoclonus is given at about 8-10 years of age, especially in an unvaccinated child from rural India, you have to think in terms of subacute sclerosing panencephalitis. If this presentation is on a recurrent basis, a jerky movement of the arms, which is causing spilling of food on the dining table, is causing difficulty in wearing clothes, etc., then juvenile myoclonic epilepsy is to be considered. And when it comes to a 35-year-old guy, whether he mentions a beef eater or not does not matter. If you read a young guy having combination of myoclonus plus dementia, though dementia word is not given, maybe initially apathy is present, then subsequently dementia component would come in, then the disease to be considered in this patient is a prion disease that is called as variant Creutzfeldt-Jakob disease. As far as the remaining choices are concerned, when it comes to herpes simplex encephalitis, the usual presentation will be illness of at least 1 to 2 days, where person will be having high grade fever with maybe a frank psychotic state. There might be aphasia, there might be apraxia. So there must be some evidence given of a CNS infection where at least fever should be given. That is why, because this fever is not given, I am ruling out A. Subacute sclerosing panencephalitis happens to be a pediatric presentation, so is being ruled out. Mesial temporal sclerosis is going to result in development of medically refractory epilepsy, and this question is definitely not talking about epilepsy, so you can solve this question even on the basis of exclusion. What I am saying is that even if you are not comfortable picking up a cortical ribbing, you are not able to interpret the EEG, if you just go by logic, you can definitely rule out the other options. I want to highlight option A ruled out, no fever present. Option B, pediatric presentation, this is 35-year-old man, and C is going to be medically refractory epilepsy for which surgery would be required. There's no mention of any epilepsy in this patient. The answer to this question is variant crucial Jacob disease, that is prion. Coming to the third one, he's going to talk about the 60-year-old chap who's presented with history of memory loss and fatigue. So in a person about 60 years of age, memory loss, I'll think in terms of possibly cortical dementia. But then he's saying he's having bradykinesia and axial rigidity. Well, that should alert me to the fact that he could be having features of Parkinson's, no? Because bradykinesia, slowness is basically seen with basal ganglia damage. Resting tremor is absent. Now that's very surprising. Why? Because traditionally resting tremor is the earliest and the most common presentation of Parkinson's disease. So I'm thinking to myself, what can this be? One hand, he's giving you a feature of dementia or dementia-like illness. Second, he's giving you features of basal ganglia damage. And most importantly, resting tremor is absent. So it can't be typical Parkinsonism. It cannot be the traditional Parkinsonism or traditional Parkinson disease that you read. It's going to be a question related to Parkinsonism variants. The question says he's having a broad-based gait with tendency to fall. Well, Parkinsonism patients tend to have a fascinating gait, where feet are kept close together. So there's something fishy about this MCQ, because on one hand, he has mentioned a feature related to cortical damage. Second, he has mentioned basal ganglia damage. Then he's also mentioned some features related to probably a cerebellar impact also. The MRI head of this patient was done, and he's giving you a two-step question where he is one asking you regarding the diagnosis and then asking you to pick up the wrong statement. Now, even if you neglect the image which are given for your convenience on the right hand side, this is a bird, we call it a hummingbird. It has a beak by which it is drinking nectar of the flower. If you focus on the image that I'm now zooming in at the moment for you, you will notice that the midbrain, you can see that this is going to be the pons, then inferior to this is going to be the medulla, posteriorly you can visualize the cerebellum. The midbrain per se is having this peculiar configuration that is highlighted here, which is called as a hummingbird appearance. So from the clinical history, the first information that I'm going to get is that this question is not a typical Parkinsonism. This question is of what we can casually write as Parkinson variant. Now, what are the Parkinson variants that you're aware of? One of them is called as MSA, multi-system atrophy. Another one is called as progressive supranuclear gaze palsy. And this hummingbird appearance, very characteristic terminology. Though I would say that even if you are not able to pick up hummingbird, it is still okay. Hummingbird appearance on an MRI head with respect to midbrain will definitely lead you to the diagnosis of this condition called as progressive supranuclear gaze palsy. These patients would be having some features which are suggestive of Parkinson disease, obviously because it is Parkinson variant, but it's obviously not going to be the traditional information. The highlight of this atypical Parkinsonism/Parkinson variant is that it will poorly respond to levodopa. In fact, the way we diagnose PSP, one method is that we actually give a trial of levodopa. With typical Parkinsonism, we get an excellent response, but because this is an atypical one, this is a variant, poor response to levodopa. B says gaze palsy. So I just said no, supranuclear gaze palsy. Why supranuclear? Because in this condition, the superior colliculus is located in the midbrain, is hampered. That is why gaze palsy can occur, which can also result in falls in these patients. Why falls, guys? You see, I can move my eyes up, down. I don't need to look up like this, no? I can move my eyes up, down, sideways. So this guy is having difficulty in moving his eyes downwards. So if you cannot see downwards, I can't see the computer that I'm writing, I can't see the ground that I'm walking, there's chances of fall. Pseudobulbar palsy. Well, you see, when it comes to brainstem involvement, because cranial nerves are originating from this area, so pseudobulbar palsy definitely makes sense for this condition. But if you look at D, he says intracranial hypotension. In fact, we read about intracranial pressure being increased. We read about intracranial hypertension, but definitely not intracranial hypotension. So the correct answer for this MCQ is option number D. It is to be solved on the basis of exclusion. The basic message from this discussion is that whenever you read bradykinesia, whenever you read about rigidity, don't be tempted to think that it is a standard question of Parkinson disease, because lots of time in the exam, they're going to give you variants. They're going to give you atypical Parkinsonism, and two very important ones that I've discussed in the routine lecture are hot favorite of our examiners. progressive supranuclear gas palsy, and multi-system atrophy. MSA, you can go through the features in the main section of the app. In Parkinsonism lecture, I have discussed them. And one of the classical MRI head findings of this condition is called as hummingbird appearance. That's mainly because of the configuration related to the midbrain. But it is not important that you have to know about the hummingbird appearance and only you can then crack the question. It is based on the fact that you had to analyze from the language of this 4-5 liner question that this is not a case. The word is not a case of typical Parkinsonism. The next question talks about an 18-year-old patient with port wine stain, mental retardation, and recurrent focal seizures. The moment you read about port wine stain, vascular malformation of the face, and then also seizures in a patient, the disease that should always occur in your mind is Sturge-Weber syndrome. You will clinically pick this up on the basis of the fact that in Sturge-Weber syndrome, you would be having a vascular malformation in the face, and probably on the same side in the brain, there is a vascular malformation in the brain also that is called as cavernous angioma. These patients will be having a difficult to control, medically refractory, or let me say difficult to control epilepsy. So he says all are true about the findings that are found in this condition except, so one of the findings written is optic nerve cupping. Well, Sturge-Weber syndrome, alphabet E per se. You see, if I look at the Sturge-Weber, the Sturge word can be used for remembering it as, or can be used as a mnemonic. Alphabet S would stand for seizures. Alphabet T would stand for trigeminal nerve involvement. In this case, what I'm saying is that there's going to be a malformation, a vascular malformation. Mark my words there, vascular malformation in trigeminal nerve distribution. I'm writing the word V to imply vascular malformation. Then it's going to cause unilateral weakness, because if you ever have a CNS lesion present, then the contralateral side of the body, there could be definitely weakness present. There could be hemiplegia. Alphabet R is to be used to remember for mental retardation component of the disease, and then comes the issue that I was talking about, that is glaucoma and even eye manifestation of ophthalmos. Well, the problem is that when you do a fundus examination in a patient of glaucoma, you definitely, due to increased pressure, can have cupping of the optic disc. So this is okay. Why? Because there's a glaucoma associated with this condition. Tram track appearance on X-ray skull. We are getting a CT scan in this case. One of the radiological finding which has been taught to you for this particular condition is tram track appearance or calcification or railroad appearance, which can be visible on a X-ray skull as well as a CT scan. Yeah, we do have tram track appearance written both for CT head as well as for X-ray skull. For medically refractory epilepsy, we can definitely go in for invasive vagal nerve stimulation. True, this is also okay. But if you look at option number D of this question, confetti lesion would basically mean hypomelanitic macules. Confetti lesion would basically mean whitish lesions on the skin, that is hypomelanotic macules. And I want you guys to remember that the term confetti lesion is basically read by you in literature of tuberous sclerosis, which is another neurocutaneous disorder. I want to highlight once again, it is hypomelanotic macule per se. Macule is always non-palpable, and this would be seen with Boonville disease or tuberous sclerosis complex, with which we usually get adenoma sebaceum. So you definitely can pick up the correct answer in this question. Again, was a two-step question. You first had to pick up it is Sturge-Weber, and then work out that option number D is not gonna be a feature because that's seen with phacomatosis, that is Boonville syndrome / tuberous sclerosis complex. The next question presents with thunderclap headache. Standard presentation, guys. Thunderclap headache is always going to be indicative of subarachnoid hemorrhage in a patient. He's saying all are true about this condition except you can definitely see blood in the meninges. You can definitely notice this white shadow that is present here is basically highlighting that this is blood in the sylvian fissure. I mean, that's the standard feature that you will always see with subarachnoid hemorrhage. Option A says hyponatremia. Well, when a person is suffering from subarachnoid hemorrhage, it's an intensely painful condition. So because of the excessive pain, there can be sympathomimetic stimulation, and studies have shown that in this extremely painful condition, there is release of a chemical from the brain, that is B-type natriuretic peptide. Guys, if you focus on the word natriuresis, there's going to be loss of salt from the body, and the loss of salt is going to explain the hyponatremia component. I also want to highlight that when it comes to subarachnoid hemorrhage, there can be ECG changes as well. The common ECG finding that you will always encounter in subarachnoid hemorrhage, in fact, that can be asked to you as what is the ECG finding of stroke? Looks very surprising, no? We have ECG findings in MIE. He said ECG finding of stroke can be, one of the ECG findings can be a QT prolongation, and sometimes you could even be having a T-wave inversion. Option number C says leading cause of death is rebleeding. There's something wrong about this statement, guys, because I've highlighted this time and again that in a person who's suffering from subarachnoid hemorrhage, the main cause of death is not bleeding, not rebleeding. It is actually the vasospasm of the surrounding blood vessels. See, wherever the damage had to occur, where the barrier aneurysm will rupture. No issues. It is the adjoining area adjacent to the berry, that's where the blood supply will rather reduce. Why? Because the body will develop a protective vasospasm to protect the surrounding area. The damage has already been done. This surrounding vasospasm is the troublemaker because it can result in brain infarction, and a loss of substantial amount of tissue and vital centers can actually cause mortality. Option number D says nimodipine is the drug of choice. Yeah, I'm going to use nimodipine to neutralize the vasospasm component of the patient. So option number A, B and D are correct. The wrong statement, since it is an accept-based question, is option number C that I want you to remember. The leading cause of death in a case of subarachnoid hemorrhage happens to be a vasospasm. It's gonna be brain infarction that will ultimately result in unfortunate mortality of this patient. And thunderclap headache can be seen even with stroke, no doubt. But then one of the most important causes for subarachnoid hemorrhage, or worst headache of my life, terminology always used is primarily for subarachnoid hemorrhage only. The next question talks about a reflex being elicited. So first of all, you can definitely see the backside of the hammer of a doctor, and he's stroking the medial side of the thigh of a patient. That's a male patient per se. So what is the test being done, guys? That's going to be the cremasteric reflex. In cremasteric reflex, you would be stroking the medial side of the thigh, and when you stroke the medial side of the thigh, it will cause a unilateral elevation of the testes. I repeat that again. If you stroke the medial side of the thigh in a normal male patient, it's definitely cause a unilateral testicular elevation. The afferent is the femoral nerve and the efferent is the genitofemoral nerve. Pure anatomical based statements. Yes, in cremasteric reflex, the root value is L1, L2, and well, the reflex per se is composed up of the afferent and the efferent. But if you look at D, what's wrong about it? He says inner part of the thigh, till then it's okay, is stroked upward and outward. No, it's rather stroked downwards. It's stroked downwards, it's not stroked upwards and outwards. So the correct answer to this MCQ is option number D. You see, basically he's just trying to see that have you elicited a cremasteric reflex in a patient. It's easy to elicit. You just need to stroke the middle side of the thigh in a downward direction, and you would be having is a unilateral elevation of the testis due to the contraction of the cremaster muscle. The answer to this question is D. The seventh one says, what is correct about the clinical sign being elicited for the image? You can see that the doctor is interlocking. One guy is checking the knee jerk of the patient, and then there's an interlocking of the fingers that is being done. This is primarily to increase the chances of eliciting a reflex, because lots of time in some patients you may not be able to elicit the reflex. So what you can do is reinforcement by asking the patient to interlock his fingers. This maneuver, which is a reinforcement one, is called as Jendrassic's maneuver. Well, Wartenberg sign, how will it look like? I'll show you an image. Wartenberg sign is what you see with respect to damage to the ulnar nerve, no? Wartenberg sign is going to be abduction. You can notice the abduction of the little finger once the ulnar nerve is involved. The image here shows that in the person in one hand, there is a very characteristic abduction of the little finger occurring. That's because of the weakness that would come with ulnar nerve involvement, that the muscles are not going to be having a balancing action. The point is, Wartenberg sign is going to be feature of ulnar nerve involvement. Hoffman sign. Hoffman sign is a variant of Babinski sign in the upper limb. Like in Babinski sign, you are going to obviously go ahead and stimulate the sole of the foot. You are going to have dorsiflexion of the great toe and fanning of the smaller toes. If the corticospinal pathway is involved, I basically wanted to remember that Babinski sign is elicited in the lower limbs, whereas Hoffman sign is the variant of Babinski in the upper limbs. So that is in the hand. Well, Gordon sign, how do you elicit it? You would squeeze on the calf muscles. This is a different method of elicitation of Babinski sign only. Gordon sign, Chaddock sign, they're very frequently asked. Oppenheim sign. In fact, there's one more question subsequently on a different method of elicitation of Babinski. But I want you to listen to my discussion of raised intraocular pressure, where I've highlighted the fact that Babinski sign can also be elicited. I mean, you don't need to stimulate the sole of the foot. You can just squeeze on the calf muscle, and you can have dorsiflexion of the great toe and fanning of the smaller toes in the patient. The answer to this MCQ is option number A. The reinforcement maneuver being done is Jendrassic's maneuver. The next question says, which of the following statements is correct about the test being performed in the patient? You can see that the doctor is trying to elicit the knee jerk. Option A says reflex is always brisk in case of motor neuron disease. I hope you recall that in motor neuron disease we will be having variants also. One of the variants is called as progressive muscular atrophy. If a person is having progressive muscular atrophy variant of motor neuron disease, the presentation is that of lower motor neuron lesion. When it comes to progressive lateral sclerosis, it is of upper motor neuron lesion, and in amyotrophic lateral sclerosis, it is a combo of the two. The wrong thing about statement number A is he has written it is always brisk in motor neuron disease, whereas in motor neuron disease you can actually have a combination of lower motor and upper motor, so it's not always gonna be brisk. B says examiner is performing the test wrongly. Yeah, maybe a correct statement, maybe a wrong statement. Let's read on C. Reflex is always absent in case of peripheral nervous disease. I just want to highlight that in peripheral nervous system, you need a complete damage. Only if you have a nerve transaction that you would be having a areflexia. Otherwise, there might be reflexes that might be elicited relatively slower. So to say that it is always brisk and always absent, the basic point is he has exaggerated the word always brisk and always absent. That is not the case. Root value is given wrong. It is L2, L3, L4. No, it is written L1, 2, 3. Actually, it is L2, L3, L4. So L1 is the wrong thing here. Well, you can see that whenever you elicit the knee jerk of the patient, you need to give support below the knee. No, the way it is being done, it's grossly wrong. It's just that you are making the person flex his neck, hitting on the tendon of quadriceps femoris. That may not be actually sufficient to elicit the reflex. You can see a sketch very characteristic shown here where the person is sitting on a chair, or even if the person is lying in the bed, you are supposed to give support below the knee with one hand and then let the leg be suspended free. And then when you hit on the tendon of quadriceps femoris, the leg will swing forward and backward and you will be able to elicit the reflex. The bottom line I want to tell is that support should be given while giving or performing knee jerk in a patient, whereas in this case the methodology is grossly wrong, which is why the correct answer for question number 8 is Bombay, that is option number beta. And this is actually a repeat AIMS question where they just showed a doctor doing it from the left side. Though in this image it looks like the patient is standing, the doctor is standing on the right side of the patient. In the actual image, when I talked to my students who had actually appeared for that particular exam in that year, they said the doctor was also standing on the wrong side and he was doing it the wrong way. The correct answer is anyway what I've just highlighted. The next question is a very interesting one. It talks about a 65-year-old uranium miner. So we are talking about some radioactivity exposure definitely. He's having muscle cramps, early morning headache. Early morning headache written in a question usually prompts to possibility of increased intracranial pressure, and then he has given both a X-ray and a CT chest. So the correlation is gonna be that there must be something that would be present in the chest that could have gone into the brain. You see, because he's talking about raised ICP, so I'm suspecting there could be increased intracranial pressure. When I visualize the CT head of this guy, definitely you will notice that the ventricles look relatively bigger in size. They are relatively looking more dilated, though I do not have the stats. I mean, I'm not measuring in millimeter. I don't have access to any kind of a computerized algorithm, but the ventricular horns look dilated. And well, this looks like either calcified lesion or it could, because it's white, right? I'm saying, or it could be a bleed, but considering the irregular appearance of the lesion which is highlighted here, and per se, I would say the irregular mass which is being noticed even on the contralateral side, it tells me that we are dealing with a contrast enhanced CT scan of the head, and there is definitely some metastatic deposits present in the brain. If you look at the X-ray of this patient, it's very nasty. There's definitely a lesion present in the right middle zone of the patient. So what has happened in this uranium miner is that he developed a lung cancer that is metastasized to the brain. And anyway, the commonest cancer that goes to the brain is small cell cancer, oat cell cancer. Uranium miner will be no different. The correct answer for this question is option number A. Basically, it's just a distraction by talking about a miner per se. The point is, if a person is going to be having a lung mass, which is small cell cancer, it's going to metastasize to the brain. In fact, this has been highlighted multiple times that the most common brain tumor is METs. So you can solve the question on the same approach as well. Non-small cell lung cancer mainly will remain localized to the lung only. It can spread to contralateral lung. Like in adenocarcinoma, we have a transbronchial spread, no? So I'm ruling out B because per se, non-small cell cancer will have a local growth, whereas small cell cancer exhibits micromets right from day one, and these micromets will explain the dissemination component of the disease. C says pleural and intracranial calcification. Well, first two do not make sense. And yeah, if you were thinking in terms of mesothelioma, then mesothelioma is what you encounter with asbestosis, no? Because pleural calcification is read with asbestosis. Here is mentioning about a uranium minor, so looks unlikely as an answer. D says glioblastoma multiforme extracranial spread. Totally reverse. He's saying tumor of the brain is going to lungs, which is more common. Lung tumor going to brain, no? It's not vice versa, na? That brain tumor. Yeah, glioblastoma multiforme is the most aggressive brain tumor, primary malignant one, agreed. But for a brain tumor to spread to lungs is extremely a rare event per se. So therefore, we have to answer common things in the exam. The thought process is it's going to be a lung cancer that's going to be metastasizing to the brain of the patient. So therefore, answer to this question is option number A. In the next question, he's talking about this 65-year-old man with dementia and poor urinary hygiene. Well, Alzheimer's disease patients will be having poor urinary hygiene also, anosognosia. They might be urinating in their pants, they might be defecating in their pajamas, and they'll not even make attempt to change their clothes. On examination, the reflexes of brisk and gait apraxia is noted. Alzheimer's disease does not have brisk reflexes. Right? In Alzheimer's disease, we don't study about white matter involvement. No, corticospinal pathway is white matter. Alzheimer's disease is a pure gray matter disease. So point against Alzheimer per se, in this case, which is option number D, and is immediately ruled out, is that in Alzheimer we don't read about brisk reflexes, we don't usually read about gait apraxia. And anyway, gait apraxia tells you which part of the brain is affected, frontal lobe. Right? Magnetic gait is what he's talking about. So if you look at the options, A says multi-infarct dementia. When you look at the CT per se, you are not able to pick up any infarcts per se. All these black spots that are present, no, these are basically like the Sylvian fissure, interhemispheric fissure. These are not any kind of infarcts which are present. So I'm ruling out option number A because multi-infarct dementia or Biswanger's disease, or even if I say small vessel disease present, the infarct should at least be visualized. B says normal pressure hydrocephalus. Now this can be a possibility because in normal pressure hydrocephalus you read a triad. The triad is DAI. Alphabet D will stand for dementia, A will stand for ataxia, and I would stand for incontinence. Well, that looks to be the answer to this question because you can notice that the horns of the ventricle, the temporal horn, the lateral horns, they look relatively more dilated. I mean, the ventricular system does not look the way it normally should. C says frontal lobe tumor. Well, I cannot visualize a tumor in this case. So what I am saying is that even if you're not aware of the triad, you can still approach the correct answer to this question by a simple exclusion because I cannot visualize any infarcts per se. Option number A was ruled out. No tumor visualized. So frontal lobe tumor is option number C is ruled out, and Alzheimer's disease is primarily a gray matter disease. You do not have white matter manifestations like brisk reflexes and even a gait apraxia. NPH has all the three things which are given in this question. Dementia is given, ataxia is given, and urinary incontinence is present. And well, I can say that the gait apraxia component is again going to contribute to ataxia. No, the person can definitely fall. The message is that in normal pressure hydrocephalus, what happens is that there is going to be increased CSF production at night. So when the ventricular system will expand, it's going to put pressure on the frontal lobe, so gait apraxia. Because of gravity, because the pressure will come down, it will also be impacting the cerebellum, so there can be ataxia component. Pressure on frontal lobe can cause urinary incontinence also due to damage to the paracentral lobule. And overall, when the ventricular system will expand from within, it will push the gray matter against the calvarium, and the pressure on the gray matter will cause cortical atrophy. That cortical atrophy will explain the dementia. First of all, you need to remember a triad present here, that is dementia, ataxia, and incontinence. And second, you need to pick up regarding the dilated horns of the ventricles in the city head of this chap, by which you can arrive at this question. So there are two ways to do it. One, get the triad right. Option number two, use the power of exclusion. I want you to be having both the capabilities to be able to solve such questions. Coming to the next question, we're going to talk about a patient who's having phakomatosis and she's on anti-epileptic drugs since childhood. What you can notice in this patient is a very characteristic acneiform lesions which are present in a very characteristic butterfly distribution. They're present over the malar eminences, somewhat on the bridge of the nose, and this gives you the clinical diagnosis of this patient as tuberous sclerosis. Well, the lesion that is given in this image is called as adenoma sebaceum, which is a presentation that is usually seen in this disorder post-adolescence. The correct answer for this question is option number C. It's a spot diagnosis. The moment you read the word phakomatosis, that's an alternative term for neurocutaneous disorders. In fact, when I, in my medical career, read the term phakomatosis first time, I thought it's something related to ophthalmology, right? Because you read about phakia or you read about pseudophakia. But then I realized that phakomatosis is an alternative term for neurocutaneous disorders, where person will be having a neurological malformation and therefore recurrent epileptic episodes or repeating seizures can definitely be encountered in the patient, which explains why anti-epileptic drugs were being used in this condition. When it comes to option number A, why it has been ruled out is because the presentation of Sturge-Weber syndrome is going to be that of port wine stain, and in the brain on the same side there could be a cavernous angioma, vascular malformation, which could explain the seizures part, but because I cannot visualize any port wine stain here, of A is off the radar. B says von Hippel-Lindau syndrome. Now, one of the characteristic features of von Hippel-Lindau syndrome that you will always gonna read is a tumor in the brain, that is cerebellar hemangioblastoma. I mean, without having evidence of mention of renal cell carcinoma or mention of cerebellar hemangioblastoma, the diagnosis of VHL can definitely not be commented upon. So that is again off the discussion. And then ataxia telangiectasia will be having dilated blood vessels. No, ataxia telangiectasia, you have combination of spinocerebellar degeneration and telangiectasias that can be noticed in the white of the eye or on the face. Telangiectasia, dilated blood vessels that can be visualized, but in this case it is more of a acneiform lesions that are being visualized on the face. So that is why the diagnosis I said was adenoma sebaceum, and combination of the two is what is called as Boonville disease / tuberous sclerosis. The answer to the question would be given as option number C. Moving to the next one. He says eye of the tiger appearance in a CT head is seen in. In fact, in this one, you don't even need a CT image. It is just to highlight that if you look at this image, you will definitely notice this is relatively looking black, and inside the black, you can definitely notice the white component present. What I'm trying to say is like the eyes of a wild animal. Like if you watch Discovery Channel in the dark, if they're shooting in the dark, right? I'm not saying that you are watching Discovery Channel in dark. If they are shooting a wild animal in the dark, right, with a night vision camera, then with a night vision camera, the eyes of the animal will look like what I'm highlighting at the moment. The eyes will basically shine out. They will look relatively white, and that is what he's trying to say, that eye of a tiger appearance is seen in. Well, the answer to this is going to be disorder in which there is iron deposition in the basal ganglia. There is iron deposition in the putamen, and that disease where you have iron deposition in the putamen is called as pantothenate kinase associated neurodegeneration. The correct answer to this question is option number delta. Why not Huntington's chorea? Because per se in Huntington's chorea, the damage occurs in the caudate nucleus, and the usual radiological finding that would be encountered in these patients would be atrophy of the caudate, which is very difficult to make up, and per se eye of the tiger is anyway not a feature. For multi-system atrophy, I want to highlight that the radiological finding is called as hot cross bun sign, and this hot cross bun would be seen in the brain stem, and at the moment it is the cortex that is being visualized. Multiple sclerosis is immediately off the radar. Why? Because this would be characterized by having finger-like projections of demyelination occurring in the brain, that is called as Dawson fingers. So since I'm not able to visualize the classical lesions that are seen in the disorders mentioned in option number A, B and C, therefore by exclusion also the answer would be given as option number A. In fact, two messages that I want you to remember is if it's going to be copper deposition in the brain, then we are talking about Wilson disease, and the radiological finding is called as giant face of panda, right? On the other hand, if we're going to talk about iron deposition, and this iron deposition is occurring in the putamen, then the disease that we are talking about is referred to as pantothenate kinase associated neurodegeneration, that is PKAN, and the radiological term is eye of tiger. So two, I would say, animal inspired signs is what I've highlighted before you. Let's get them right once again, guys. Giant face of panda and eye of a tiger appearance. And apart from this, I've already sensitized you to a bird in the brain also, right? We spoke about hummingbird appearance on a MRI or a CT head. This is going to be with respect to the damage to the midbrain, especially the superior colliculus, and the disorder that was discussed was called as PSP, that is an atypical Parkinsonism called as progressive supranuclear gaze palsy. The answer to this question is delta. Moving on. A 13-year-old patient presented with a Glasgow coma scale value of 7. That's really bad. Patient is going into coma with nuchal rigidity and bloody CSF. So what is the diagnosis, guys? You can definitely see blood in the interhemispheric fissure. You can notice the blood present in the sylvian fissure. Considering the findings given here, nuchal rigidity, bloody CSF, blood in the meninges, the clinical diagnosis of this patient is going to be subrecurrent hemorrhage. And he says, what is wrong about this condition? Definitely we will be having blood in the sylvian fissure. That is what I highlighted, and I've just zoomed in for your convenience. This is the sylvian fissure and the white is the presence of the blood. What does sylvian fissure do? It separates the parietal from temporal lobe. In any neurological condition, seizures can be seen, especially if there is irritation of the brain parenchyma, or in fact, if there is an extension of the bleed into the brain parenchyma, the cerebritis component can explain seizures also. Intraventricular extension, yes, if somebody is having subarachnoid, it can bleed into the ventricles also. But if you look at D, ceftriaxone, that's used for meningitis, man. The topic is subrecurrent hemorrhage. There is no infection. The correct answer for this question is option number delta. Why? Because ceftriaxone is anyway used for management of CNS infections and not for a CNS bleed. For management of subrecurrent hemorrhage, we will be using nimodipine, which will prevent the protective vasospasm. And as I highlighted, vasospasm is one of the big killers when it comes to the topic of subrecurrent hemorrhage. The next question talks about a 45-year-old woman who presents with left-sided ptosis. So we are talking about a third nerve palsy here. There's also presence of headache, and the patient is not very cooperative during physical examination, probably because of the headache component. A CT and a ECG was done. The point is, in the CT, you can definitely notice presence of blood in the meninges. This is interhemispheric fissure where the blood is present. This is sylvian fissure which blood is present. So obviously the diagnosis of this patient is subrecurrent hemorrhage, and we are anyway aware that if it's going to be a berry aneurysm in the posterior communicating artery, then it's a possibility that it can press on the oculomotor nerve, and thereby there could be a third nerve palsy explained in the question. Subrecurrent hemorrhage is given in all the four options here. He is rather asking you the ECG finding of subrecurrent hemorrhage. I want you to remember that in patients who are having SAH secondary to, I would say, the dysregulation of the autonomic nervous system, because there's a bleed in the brain, the head ganglion of the autonomic nervous system is the hypothalamus. There could be a hypothalamic malfunction. As a result of it, they've documented ECG findings which are coming up. One of them is going to be T-wave inversion, and a second finding that's very characteristic of the disease would be a prolongation of QT interval. Well, how much is the normal QT interval, guys? Then I hope you recall it's going to be between 360 to 440 milliseconds, and anything more than 500 milliseconds is going to be grossly abnormal. Even if I do the task of making it or making an attempt to count here, you see what I'm trying to say is that in this particular question, ECG is just a distraction. You don't even need to actually count the squares in the ECG per se. Though I'm going to do that activity before you, I want to highlight the fact that let me say this is going to be the time when the Q wave would be coming. This is when the T wave is entering, and now we are going to count the number of squares which are going to be in between these. So I can count 5 here, this is 5 here, that is 10. You can count another 5, that is 15, and you can add 2 more. So if I add this would be approximately 17, right? So 17 small squares. Guys, let's do some mathematics. One small square is going to be approximately a range of 40 milliseconds, right? So 17 into 40 would be 680 milliseconds. That is much almost double of what is normal. That is why, I mean, what I'm saying is, guys, even if you don't count it, no, let me just change the color to make it much more visualized for you. You see, what I've done here is just counted the number of small squares. It's going to be turning out to be 17. One small square is 40 milliseconds. That's 0.04. So if you multiply, the value 680 milliseconds is definitely higher than what it is. But in actuality, you don't need to even count the number of squares. Just remember my words. ECG finding of strokes could be one T-wave inversion, another can be a QT prolongation, which could be occurring, and that also explains why sometimes arrhythmias can occur in people with subrecurrent hemorrhage. The correct answer for this particular question would be option number A. Coming to the next question, he's talking about a mixed martial arts boxer losing his match by knockout. Well, MMA is pretty a bloody sport. 1 week later he's having daily headache, vomiting, disorientation. So this tells me the fact that the injuries that he sustained during the MMA fight have resulted in a traumatic brain injury and is now causing a raised ICP, because the standard features of raised ICP are highlighted here. He has gone into coma. You see, GCS of the person has turned out to be less than 8, and the fundus is showing evidence of papilledema. So everything is talking about a traumatic brain injury here. And when I do the CT scan of this guy, you definitely can notice on the non-contrast CT head, this is going to be left, this is going to be right. On the right hand side, maybe he was by the elbow on the side of the head during the submission match. So there is a concavo-convex bleed present. And whenever you see a concavo-convex bleed present in the brain parenchyma or related to the brain parenchyma, you always have to think in terms of a subdural hemorrhage. The correct answer to this question is option number C. I'm ruling out option number A and B because they basically mean the same. Intraparenchymal bleeding would mean a lobar bleeding, and it would be rather ill-defined opacity in the brain parenchyma of this patient. When it comes to subrecurrent hemorrhage, there should be blood in the meninges, that is in the sylvian fissure or interhemispheric fissure. But since you can visualize a very characteristic white hyperdensity present here and the patient is presented within a week, I would like to call this an acute subdural hemorrhage. The answer to this question is option number C. Coming to the next question, is asking about what is correct about the IC bleeding shown in this case. So one, you can notice a very characteristic concavo-convex bleed present in this case on the left hand side. This particular case is having a chronic subdural hematoma. Why I'm saying chronic is because the blood has been reabsorbed, the area is looking relatively black. So it is a hypodensity, and because hypodensity appears later, so that is why it's a chronic subdural hematoma. I've discussed this in the SDS topic. Now, if the bleed is going to be white, we're going to call it acute. If the bleed area is going to look black, it's going to be chronic. And anyway, black, the term used is hypodensity, which justifies the answer. Why answer is not C is because in epidural hematoma, it would be a biconvex bleed present, whereas the configuration of the bleed per se would help you in identifying the condition. I would once again try to highlight the two bleeds which are shown in this case. I'll just put sides first so that we get the perspectives in the right way. You can notice a very peculiar biconvex bleed present. I can use the word lenticular hyperdensity present. So this image that is shown here is that of a right-sided extradural hemorrhage, whereas if you look at the next image, you can notice a concavo-convex bleed present in this case. Pretty a nasty one, will require a decompressive hemicraniectomy because of the mass effect which is being caused by it. So this person is having a right-sided subdural hemorrhhage. Coming to question number 17, he is talking about a 55-year-old diabetic patient who's got sudden onset hemiparesis and facial asymmetry. So we are thinking in terms of cerebrovascular accident, and I am suspecting this to be middle cerebral artery territory stroke primarily because he is talking about facial asymmetry. He is talking about a sudden onset hemiparesis, so it's probably internal capsule that would be involved. Now, when you are evaluating the CT scan of this guy, the thought process of yours would be that is it a brain hemorrhage? That is, it's going to be a hyperdensity versus a hypodensity for ischemic stroke. You can see a white shadow in this case, which is going to be suggestive that either this is a bleed or it could be an organizing thrombus. I want to highlight that if everything that looks on a CT scan is white, it's obviously suggestive of a bleed. But then if the bleed was present, it would have been diffuse bleeding like this in the brain parenchyma. Here, this is more of a straight line, which means that there is a thrombus inside the middle cerebral artery. You see, this is the area where the putamen will be. This is the area where the lenticulostriate artery would be present. So there is a thrombus inside the lenticulostriate artery. Some extravasation of blood can definitely occur later. But the point is, there's a thrombus inside the middle cerebral artery, and the classical term that is used to describe this is referred to as hyperdense MCSI. Hyperdense MCS sign is a feature of acute ischemic stroke. The query of most doctors is, sir, on one hand you are saying ischemic stroke, it should be black. Yeah, the area supplied by it will be becoming black subsequently. But at the moment, because this is an early presentation of ischemic stroke, please remember the thrombus which is developing in the blood vessel will actually look white. In the later part of the same illness, you will notice that maybe after 8 hours or 10 hours, the area supplied by this artery, that's where the hypodensity will appear. In brain hemorrhage, there is spilling of the blood in the brain parenchyma. I'm definitely ruling out lobar hemorrhage in this case because anyway there's no spillage of blood per se. Apart from this, when I say subrecurrent hemorrhage, there should be blood in the sylvian fissure. Please appreciate that sometimes when the thrombus is developing adjacent to that, a minor bleed can also be present. But the main feature that I want you to highlight in this particular case is not that it is a lobar hemorrhage, it is actually a straight linear opacity which is present. So that is why I'm focusing on option number A. And cystic encephalomalacia is a complication that can develop post-stroke. Like if the blood supply to the brain is gone, then the area will die, and the dead area there might be a cyst formation. So point number B is a post-stroke complication. It's degeneration of the brain that would be present. But when it comes to option number A, the word is hyperdense middle cerebral artery sign. That is a feature of early presentation of acute ischemic stroke, which is why option 2 or option number A is the correct one for this question. Coming to the next question, he is basically showing you a patient with facial asymmetry. As you can notice, the person's smile is deviated towards one side. So initial impression is it could be a case of Bell's palsy, that is infranuclear lesion. But now to see whether it is infra or supranuclear lesion, you will request the patient to frown and produce lines on the forehead. If you look at the image of this person, you will notice that there are definitive lines that can be visualized on both the left as well as on the right hand side. So my first message is this is not a case of Bell's palsy. This is not a case of lower motor neuron lesion. Why? Because in Bell's palsy, the lines on one side of the forehead would be completely absent, whereas in this case, you can definitely see the lines on both sides. So frowning is definitely preserved in this case, which highlights it is a supranuclear lesion. That's the first message. Now we need to figure out which side is the lesion present. Is it gonna be left or is it gonna be right? So let's look at the face of this guy. You will notice that on this side the face is looking normal because you see the tone of the muscles is normal. That is why the face is deviated to one side, because this side the muscles can work. But on the opposite side there is distinctly a weakness present, and you see whenever there is an imbalance, whenever there's an imbalance between the muscle power, that is when there's a facial asymmetry. So the message in this chap is that he is having a supranuclear lesion. And where is it present? It's on the right hand side. The correct answer to question number 18 is alpha. The usual query of most doctors first is, why is it not Bell's palsy? Why is it not gonna be answered by you as infranuclear lesion? I provided the reason. Frowning is preserved. Second, you will notice that when the face is deviated like this side muscle must be normal, no? And the other side would be weak. There's an imbalance of muscle. That is why the face deviation is present. So this definitely shows us that this guy is having a right supranuclear lesion. Answer to 18 is A. In question number 19, he says 7-year-old girl is easily distracted in the class and exhibits a poor scholastic performance, and the EEG is showing this very characteristic finding, which is called as 3 per second spike and slow wave pattern. Even if you can't measure that it is every 1 second, because obviously they have not given any vertical markers for you to find out whether the recording is over 1 second, 2 seconds or 5 seconds, but the message is that spike and slow wave, right? I mean, slow, why we are calling it slow? Because as such, the rhythm in the brain of a person will be relatively more faster. I mean, most of us operate between alpha and beta rhythm. The term here is 3 per second spike and slow wave pattern. This is a very characteristic EEG, which is given even in the epilepsy and EEG lecture, and is very hard to miss. I mean, 2 EEGs which I personally feel should be easily picked up by you is one 3 per second spike and slow wave, and the second is going to be periodic sharp wave complexes of prion disease, which can be definitely asked. The answer to this question is option number beta, and you don't even need EEG to solve this question. No, the language is so characteristic. Poor scholastic performance, easy distraction. Like the patient is just sitting staring at the face of the teacher intermittently, like the teacher is talking to the child and suddenly the child will be having vacant stare. Absence seizure can be managed both with help of valproate and ethosuximide. The correct answer to this question is option number beta. In the next question, you definitely can notice dorsiflexion of the great toe and fanning of the smaller toes. So one thing is clear, that the doctor, whatever maneuver is doing, he's trying to elicit an extensor plantar, which tells you the fact that the person would be having corticospinal tract injury. There is some problem with either the brain or the internal capsule, or maybe the corticospinal pathway in the spinal cord can be involved. He says, what is the method of elicitation? You see, in Chaddock sign, the stimulus is given. The stimulus is given not in the sole of the foot. The stimulus is given in the upper part of the foot, that is from the lateral malleolus. Remember my words very characteristically, that in Chaddock sign, you are trying to check for damage to the corticospinal pathway by not stimulating in the sole of the foot like in Babinski sign. It is in the upper part of the foot, lateral malleolus to the little toe. The finding is still the same, that is dorsiflexion of the great toe. Oppenheim sign is when you will stimulate over the shin of this person in a downward fashion. So this particular question is having answer as option number beta. Option number C says Babkin sign. Now there's Babinski sign and there's Babkin sign. Babkin, you see, I repeat the statement, Babinski versus Babkin. So Babkin is going to be a neonatal reflex, that is palmomental reflex. I want you to go through the data in pediatrics where you will find this name written, palmomental reflex, and the alternative name is Babkin, which can obviously be confused as Babinski. In Gordon sign, the method of elicitation is different. I'll just use a different ink to highlight it. The method of elicitation of dorsiflexion of the great toe and Gordon sign would be to squeeze on the calf muscle of the patient. So though in this particular diagram I have tried to highlight the other hand, which might look like squeezing the calf, is actually stabilizing the leg of the patient. It's not that he's squeezing the calf muscle. And anyway, in the exam, I mean, if the image is given of mainly the shin being stroked from the arrow that I highlighted, then it's going to be answered as Oppenheim sign. If he's just showing one hand of the doctor squeezing the calf muscle and you get dorsiflexion of the great toe, you will get Gordon sign. The learning point for you is that Babinski sign can be elicited in different methods. It can be stimulus, not in the sole, in the upper part of the foot, that is Chaddock sign. You can stimulate on the shin, that is Oppenheim sign, or squeeze the calf muscle, and that is called as Gordon sign. It is BCG, mainly Babinski sign, then Chaddock sign and Gordon sign, which are extensively asked. So I decided to just deviate from the standard norm and ask you regarding Oppenheim sign also. All of them are basically implying damage to the corticospinal pathway, period. I mean, that's the main concept that you need to understand. Moving to the next question, he has given an MRI head of an 8-year-old boy who's having difficulty in copying classwork from the blackboard. So maybe a problem with visual acuity or refractive error, and daily headaches for last 6 months. Well, the first impression or the first differential diagnosis from the history given would be suggestive of refraction error, but because he has done an MRI also, there must be some kind of a intracranial space occupying lesion, and you definitely can notice in this case a wide area which implies calcification in the brain in the area where pituitary is supposed to be present. Well, the MRI head has accidentally picked up in this guy whom I was suspecting of having a refractive error, a craniopharyngioma. So whenever you deal with a child who is having refraction errors and headaches on a constant basis, yes, you need to rule out the obvious things, but even brain tumor should be ruled out. Craniopharyngioma is a supracellular tumor that can contribute to intracranial calcification, and anything that's going to be grossly white on a CT/MRI is either going to be calcification or is going to be bleed. This is actually a cystic tumor. Inside this is obviously liquid, but the periphery of it is relatively solidified. It has a calcium deposition. The tumor is derived from Rathke's pouch. And well, what is the reason for difficulty in copying classwork from the blackboard? This condition can actually compress on the optic chiasma, thereby resulting in visual deficit, that is bitemporal hemianopia. So the child will be able to copy the medial part, but the lateral part of the classwork he will definitely have a difficulty in visualizing and therefore noting as well. Option number B, C, D are relatively ruled out because per se when you look at B or C, they don't have a calcification, and pinealoma will be much more superiorly located. I mean, pineal gland will be located relatively posteriorly. If I just put a pointer here, or I can just put a mark here, pineal gland would be situated in the following area, and pinealoma would be relatively more common in adults, and most of the time there would be a third nerve palsy as well. The next question talks about presence of adenoma sebaceum in a butterfly distribution, but along with that he has also shown a very interesting finding that if you look at the nail of the person, you will notice some fleshy growths which are developing here. These growths are coming from below the nail. The lesion is basically called as Koinen tumor and is also referred to as subungual fibroma. So therefore the clinical diagnosis of this patient is tuberous sclerosis complex. When it comes to the image here, you will notice, and this is what my students told, and one of them actually made a silly mistake, that he knew that this was basically an angiofibroma. Adenoma sebaceum is called as angiofibroma, but he casually marked it as angiolipoma. But you see, angiolipoma per se is angiomyolipoma that is encountered in the kidney in patients of tuberous sclerosis. The correct answer for this question is option number beta. You see, in the exam, in a pressure cooker situation, there is a very high probability that you might miss out words. So careful reading is of paramount importance. Like I just showed before you that angiomyolipoma was also given in the options, whereas the lesion which is present here is adenoma sebaceum, also called as angiofibromas. It is, I would call it, error of judgment. That is, I mean, most of the reason I would say why people tend to have ranks lower than expected affected is because the negative marking tends to be on the higher side. So you need to reduce your negatives as you are doing these questions primarily. Answer to this question is beta. We come to 23, which I've already highlighted. It's a subungual fibroma. It's coming from below the nail, and the alternative name for this is called as Coinen tumor. The first impression when you look at it is because the nail looked relatively yellowish. So a lot of guys casually thought that this could be actually a fungal infection related to the nail. There is also a white line which shows as if the nail is getting broken. So most people thought it could be fungal infection. What they missed was these fleshy growths that are originating at the nail plate per se. These are subungual fibromas and are found in tuberous sclerosis complex. Technical name has been highlighted, Coinen tumor. A 13-year-old child with cirrhosis and recurrent episodes of ascites, so this tells you that the liver of the kid is affected, is having the following eye findings. You always know this question whenever there's going to be liver damage shown by eye finding, that is going to be having this greenish brownish ring in the periphery of the eye. We are always talking about possibility of Wilson disease, and well, this is a KF ring. He's saying all of the following are seen in this condition except A says elevated serum copper. Well, KF ring is present in patients of Wilson disease. Wilson is characteristically a disorder where there is more copper in the tissues, but apart from that, there is more copper inside the RBCs also. So now because there is more copper in the RBC, when the RBC will burst, there will be hemolytic episodes that will be occurring in this condition. These hemolytic episodes will explain the anemia component as well as elevated serum copper. I repeat what I said, guys. I said traditionally in Wilson it is tissue copper that is elevated, but even blood copper can be elevated secondary to hemolytic episode or episodes that can occur in this patient. So A is fine. B says dysarthria. You see, in Wilson disease, you can be having neurological manifestations as well. Basal ganglia is affected. Copper will be affecting the basal ganglia. It could be affecting nucleus like putamen and globus pallidus, that is lenticular nucleus. That is why Wilson disease per se is also called as hepato lenticular degeneration. And if you just go back to physiology, then lenticular nucleus per se is going to be a combo of globus pallidus and putamen. What I want you to remember is that in this condition, what you will not get is Fanconi's anemia. Well, Fanconi's anemia happens to be congenital aplastic anemia. In Wilson disease, what you can have is increased copper in the blood, right? So more copper in the blood would mean that there would be more copper in the urine also. And if there's more copper in the urine, it can damage the proximal convoluted tubules and it can contribute to development of what is called as Fanconi syndrome. I want to remind you from the kidney section, this is a question which is a combination of kidney plus liver plus the CNS aspect. Fanconi syndrome is damage to the proximal tubule of the kidney, especially encountered in patients of Wilson disease or outdated tetracycline administration. But the bottom line is, guys, we are having hemolytic anemia in Wilson disease due to excess copper and not a Fanconi's anemia, which happens to be congenital aplastic anemia, and therefore C is the answer to this question. Kidneys are involved in Wilson, yes, and that is proximal tubular damage, which is also called as renal tubular acidosis type 2. In the next question, he has shown a non-contrast CT with a very characteristic hyperdensity. You can see this is left, this is right, and on the left side there is a spillage of blood in the brain parenchyma, that is intraparenchymal hemorrhage. So the correct answer for this question is option number C, left IPH. This is very common with respect to the lenticulostriate artery, which happens to be a branch of the middle cerebral artery, and most of the time the manifestation seen will be that of capsular stroke. In capsular stroke, as compared to cortical stroke, features like aphasia, apraxia, etc. will not be present. It will either be a pure motor or it will be a pure sensory manifestations developing in the patient. In a rural pasting, a 35-year-old farmer has come to the OPD. You definitely can notice the abnormality with respect to the legs of this guy. So you definitely are aware of, from PSM domain also regarding 1 stick stage, then 2 stick stage, and that is when we are talking about a farmer who's eating kesari dal. Kesari dal would be having a toxin that is called as BOA, that is beta-oxyaminoalanine, and this toxin can actually contribute to development of a neurological manifestation that is called as neurolithyrism. Skeletal fluorosis, if I had to give as an answer, which will again have deformities, you must always have an image showing mottling of the teeth, because in this case per se mottling of teeth information is not given, so it is unlikely to be answered as skeletal fluorosis. And anyway, the classical stick stage, 1 stick stage, 2 stick stage, and then a crawler stage is a feature that can be countered with neurolithyrism. Tropical spastic paraparesis would be seen with HTLV1, and a person will mostly be wheelchair bound because there is paraparesis, and Guillain-Barré syndrome will present present anyway, not walking. Guillain-Barré syndrome has flaccid paraplegia, so a person definitely cannot stand, not even with the help of two sticks. Even if you give him crutches, even then a person may not be able to stand, because truncal paralysis and arm paralysis can also happen in Guillain-Barré syndrome. So the best diagnosis for this patient is on epidemiological perspective, the PSM domain coming up. You're sitting at a primary health center, a farmer has come with these kind of details, then you have to think in terms of neurolitharism, that is food adulteration. The next question is very characteristic, because you will notice that on the left side, the palpebral aperture is relatively reduced. Because the palpebral aperture is reduced, I'm taking this to be a feature of ptosis. Then you will also notice a divergent squint occurring in this patient, in a sense that lateral rectus is sixth nerve, medial rectus is the third nerve, and it looks like as if the lateral rectus supplied by the sixth nerve is unopposed. Also, if you compare the size of the pupil on both sides, you will notice that on this particular slide, the pupil looks relatively, slightly, at least as compared to whatever is the palpebral fissure present, it looks relatively bigger. So there are three findings which are present: narrowed palpebral aperture highlighting the ptosis component. There is a divergent squint present in the patient, which favors the diagnosis as third nerve palsy. You see levator palpebrae superioris is gone, medial rectus is gone, and that is why the divergent squint has developed in this person, and will also be having a sluggish reflex to light. In a very tall patient with arm span more than height, standard question on Marfan syndrome, the thumb projects beyond the palm when flexed. So one is thumb projects beyond in you and me, thumb is not going to project below the palm. If I am going to show my hand to you, right, it's not going to happen. And in this patient, however, he is showing another finding, that if you are using a thumb and the little finger, and you trying to basically form a finger around the rest of this guy, and you can see there is overlapping in this image. There is overlapping of the terminal phalanges of the thumb and the index finger. I want to highlight the fact that suppose gender is female, if it's a girl and she is very thin, there's a possibility that in a thin girl you might be able to approximate like this, but still the overlapping of terminal phalanges would be relatively limited. You might be able to touch, but overlapping is slightly lesser. This is a feature that is seen in Marfan syndrome and is called as Walker-Murdoch sign. Thumb sign and Steenberg sign are both the same. In fact, I can just show you the image that will make it relatively clear to you. In Marfan syndrome, one, you will be having relatively long fingers, long slender fingers that you call as arachnodactyly. Steenberg sign is per se when you flex the fist or you make a fist, the thumb will project. That is Steenberg / thumb sign, both mean the same. Whereas Walker-Murdoch is what I just highlighted. Overlapping of the word is overlapping of the terminal phalanges of the index finger, or let me say the first finger and the thumb per se, or the first finger and the last finger. You can, traditionally you can use any of the fingers to evaluate it. You can use your longer digits also, but he says that technically, what you should do is you should use the first and the fifth fingers, and if the terminal phalanges or the distal phalanges are overlapping, it is suggestive of a positive Walker-Murdoch sign. This can be false positive in very thin persons also. The correct answer to question number 28 is option number delta. Moving to 29. It says, which of the following is not a component of the prognostic index of Naser in a patient whose naked eye examination is shown? So there are two informations provided here. One, you can definitely pick up the greenish brownish ring in the periphery of the cornea, which is the KF ring. And second, you are aware that in Wilson disease, because the liver will undergo cirrhosis, you will be evaluating the patient on the basis of Naser's index. Like I've highlighted MELD score, child pug classification for evaluating a person who is suffering from liver cirrhosis. At the moment, I am saying Naser's index is used to decide for need for liver transplantation. The word is Naser's index is used to decide for orthoptic liver transplantation in a patient of copper toxicity, that is Wilson. The components are serum bilirubin, INR. Those are standard presentations including liver enzymes, but urinary copper is definitely not a component. Yes, I want to highlight urinary copper is a screening test for Wilson disease, because if there's in Wilson more copper in the blood, it will come in the urine also. So 24-hour urinary copper is a screening test for Wilson disease, but it is not a part of Naser's index. From the liver topic and CNS, this is a I would say question which is based on integration of the two systems. A 35-year-old male presents with bilaterally asymmetrical ptosis and diplopia and watching TV or working on a laptop. You see, the basic problem is ptosis when the person is stressing his eye muscles, and that's the standard presentation of myasthenia gravis. In myasthenia gravis, the manifestations of ptosis and diplopia come when the person is using eye muscles like fiddling around with a smartphone or maybe watching television or working on a laptop. So since the clinical diagnosis, though myasthenia gravis, I agree, is more common in females, but the point is it can be in male also. Whenever you read about asymmetrical ptosis developing in a patient of gradual onset, right? If it is sudden onset, it could be a rupture of very aneurysm. If sudden onset, could be third nerve palsy, which could be due to various reasons. It could be even Miller-Fisher syndrome. But if it's a gradual onset ptosis, asymmetrical variety, myasthenia gravis is on the agenda. And for evaluation of myasthenia gravis, ideally we do a tensilon test. If tensilon test is not an option, we can go in for ice pack test. I've highlighted that in ice pack test, when you apply, you can put ice in a glove, put it over the eye. What this does is that it inhibits the activity of the enzyme that degenerates acetylcholine. If you decrease the activity of acetylcholinesterase, the enzyme cholinesterase is going to destroy acetylcholine. If you decrease the activity of the destroyer enzyme, then acetylcholine will be able to stimulate the muscle for longer duration. And if you stimulate for longer duration, the symptoms will reduce. The test is ice pack test, and the efficacy of this test is equivalent to that of tensilon test. That is why nowadays most doctors hardly do a tensilon test. Everybody is more comfortable checking antibody titer, doing a ice pack test and electrodiagnostic tests. Nerve conduction velocity will help you evaluate peripheral neuropathy, but not myasthenia gravis. This is not a muscle disease. This is not a myopathy. It's not a myositis. So since we are not having a neuritis or a myopathy or muscular dystrophy, so that's why the remaining options have been ruled out. The inferior two options, C and D, are related to muscle disease. This is characteristically a disease of neuromuscular junction. Whenever you read about a gradual onset asymmetrical ptosis with a diurnal variation, like what I mean by diurnal is person will go to office, will work on a laptop, that is when the ptosis will be triggered. So in morning the person might be fine, but by afternoon or by evening while working on a professional front, there could be triggering of ptosis in a patient of myasthenia gravis. This image is highlighting the same thing. You see, you can notice a very characteristic ptosis present in this lady, and once you have used a ice pack test, you can notice that the ptosis component has become slightly reduced. The palpebral aperture looks relatively better. The next question talks about a diagnosis on the basis of the image shown. You can see a malformation. Literally, there is a mass which is hanging from one side of the face. No, it is not a lipoma. This would be a plexiform neurofibroma. This can be a short case in surgery for you as well. Proteus syndrome is characterized by excessive growth of especially the extremities. It is mainly the hands and the feet that will become relatively bigger. So I am ruling out Proteus syndrome. It is the extremity size that will become relatively bigger. Rhabdomyosarcoma will mainly be ocular or could be present anywhere else also after related to muscles, but then unlikely to be present in the trigeminal nerve distribution. The highlight of the current topic that we're studying is that in the trigeminal nerve distribution, you are having this particular disorder, which is technically called as plexiform neurofibromatosis. A malignant tumor, again present anywhere in the body, can be malignant fibrous histiocytosis. Like you're aware, the benign tumor of the body anywhere, soft tissue tumor I'm talking about, is lipoma. The malignant tumor of soft tissue can be malignant fibrous histiocytosis. It is the location which is clinching the diagnosis in this case. The following MRI was done in a IV drug user. Now, patients who are IV drug users can definitely become immunocompromised also. They might even due to needle sharing get AIDS. And if a person is having AIDS, then one of the opportunistic infections that can come up is cryptococcal meningitis, especially when the CD4 count of the patient will be dramatically reduced to less than 200. And when cryptococcal meningitis will come up, you will be having an MRI head showing this characteristic soap bubble appearance. The correct answer to this question is option number beta, that is a soap bubble appearance. Traditionally, you read about soap bubble appearance in orthopedics with osteoclastoma, but today we talk about a soap bubble with an MRI head also. Starry sky appearance is a feature that you encounter with neurocysticercosis, definitely not. Dense MCA sign is seen in early phase of acute ischemic stroke. Ring enhancing lesions can again be neurocysticercosis or could be even a tuberculoma. And the differences between the two have been highlighted in the main lecture, that you can differentiate between NCC and tuberculoma by doing a MRS, that is magnetic resonance spectroscopy. In the next image, you will notice that this CT head is showing this black shadow. The black shadow looks to be air. Option number A says ring enhancing lesions. Well, ring enhancing lesions would be present mainly in the brain parenchyma. In this case, the brain parenchyma looks relatively clear. These black spots are again representing air in the brain tissue. He had a trauma, frontal brain trauma, following which pneumocephalus is present. So though this is a spot diagnosis, I'm ruling out options by saying ring enhancing lesions are mainly in the parenchyma. Brain abscess, if you call this black area as a brain abscess, then I would say that brain abscess would be a circumscribed black shadow. It would be roundish in appearance. So having so many brain abscesses is unlikely. No? Hair is gonna be black. Brain abscess tissue also can be black. So brain abscess looks unlikely as a possibility. Plus, usually in brain abscess, clinical history should be given us some suppurative process. It could be osteomyelitis, it could be bronchiectasis, it could be TET spell in pediatrics, but at least some evidence of infection should be there. And brain infarction will have hypodensity, but then all these circumscribed black areas where I've just put stars, they are unlikely to be areas of brain infarction. This is pure air. There's a fracture of the bone which could have resulted in this. All are true, but the brain tumor associated with the following histopathological finding, except you can definitely pick up and is a very frequently asked histopathological image, that would be psammoma bodies. You read about psammoma bodies in serous cystadenoma related to the ovary, then you read about psammoma bodies in papillary cancer of thyroid and the kidneys, and then meningioma. He is here talking about association of meningioma with the aspects which are written here. Most frequent cytogenetic abnormalities, deletion of chromosome 22. You see, ideally though, you should remember chromosomal and enzymatic and gene defects for everyone. There's a possibility that you may not be remembering it. So let's neglect A at the moment. Let's look at B. Association with neurofibroma 1. NF1 is mainly related with optic glioma. So unlikely as an answer. So I'm thinking between A and B to the answer. C says intracranial calcification. This I know. Meningioma is a brain tumor that exhibits intracranial calcification. Psammoma bodies I've already picked up, so I have to select between A and B. I want you to remember that neurofibromatosis 1, von Recklinghausen disease, is related to optic glioma, whereas meningioma is associated with neurofibromatosis 2. The correct answer to this question is option number beta. I have usually seen a low strike rate in this question, so that is why I put it. I mean, sometimes there is a possibility that between option number A and B, and I mean, it could be any choice per se, there could be very closely matching terms. And genetics is something which is like, you need to feed on it on a regular basis to be comfortable with genes and chromosomes. To the level that if I say, okay, tell me diseases related to chromosome 22, you should be able to jot down or at least mention 3. Yes, a disease related to chromosome 21, you should be able to tell. So ideally, though, for every disorder that you study, whatever chromosome that you note, you should note it down and then create a list retrospectively. Like chromosome number is written, chromosome 17, for example, very frequently in a lot of medical disorders, you write the disorders related to defects of chromosome 17. If you try to make a list like that, then you would be, though it's a pathological domain, that will make you more comfortable with remembering the genetics or disorders. The answer to this question is beta. Then he's put a mark on this thick blood vessel. This is internal carotid artery. You definitely can visualize the vertebral artery here. I'm just putting VX here, which is uniting to form the basilar artery subsequently. But this lateral thick blood vessel that is coiling up is internal carotid artery. Actually, when this question came, a lot of guys casually answered communicating artery, vertebral artery. The point is, this was thickest blood vessel. One of the biggest caliber blood vessel in the brain is internal carotid artery. So, I mean, the guy whom I spoke to, he himself said, sir, this was a very thick blood vessel. But he unfortunately marked as communicating artery. He said, what made you think that? He said, sir, I just lost reasoning at that point of time. You see, lots of time in the exam, you have a brain freeze. The brain just stops working. So you have to prevent that from happening, sir. That comes with practice. That is why the discussion is being done, and the discussion is being done at a fast speed. We come to the next one. The CSF electrophoresis of a patient shows oligoclonal bands. Now, don't waste time here trying to interpret the image. The only condition in central nervous system where you read about CSF electrophoresis is gonna be autoimmune disorder where you have UTTA phenomenon, that is multiple sclerosis. I mean, you can solve this question by simply reading the word CSF electrophoresis, because nowhere else do you read about CSF electrophoresis. You read about hemoglobin electrophoresis, no? CSF electrophoresis because you can demonstrate oligoclonal antibodies against the myelin in the brain. It's antibodies against the myelin component of the neurons per se, and as a result of it, you could be having optic neuritis, UTTA phenomenon, and multiple neurological white matter degeneration that can occur in a person of multiple sclerosis, which is best managed with beta interferon. The answer to this question is option number C. So these are a couple of details which I wanted you to practice and listen here. So I would now like you to scroll through this entire video fast before you just wind up with the video. I want you to scroll through the images once again in quick 5 minutes and just try to recall the main core issues that I've highlighted. I mean, I'm not asking you to cram the answers. All I'm saying is just look at the images once again so that your brain can register. You would be having a visual stimulus that would be imprinted, and therefore this definitely should help you in improving your strike rates. Thank you so much.